about having them taken out. We've found that breast implants, when people come in here to have them taken out, there's sort of a myriad of problems people can present with that may be associated with the breast implants being in place. People come in with all kinds of stuff ranging from pain to less specific things like fatigue and other issues. And it's interesting because implants, one thing for sure we know pretty easily is these implants being placed, they're typically placed under muscles. Not always, but they're usually placed under your chest muscle. And that just placement into that location causes a lot of strain on the chest. It stretches the muscle, it creates a sort of tightness feeling. Some people have trouble breathing, it can cause pain. So just from a mechanical perspective, that implant being in place can cause a lot of issues. The implant, in order to sort of live in your body, a capsule has to form around it. It's a normal process of anything. Even if you put like a joint in the body or something like that, the body will make a capsule around implanted stuff. So that capsule sometimes can thicken and make things even worse. It can get tighter or harder, and that can make that whole mechanical process even worse. But in addition to the mechanical piece, the implants are made of materials that might elicit immune type reactions. And we do know that there have been studies in the past that show that the body can mount an immune reaction to things in the implant, like silicone or other things in the implant. And so you can have immune phenomena, and that immune reaction could lead to other more systemic immune things. We think it's possible. But then there's sort of a third group of things that are difficult to attribute to, mechanical or immune stuff. And so, things like fatigue and weight gain or sort of brain fog type things. And those are less specific, and it's harder to know how those might be connected to implants. But we're actually starting to really look at this more closely. And as if we've taken a lot of implants onto people at this point, and from the very beginning, we've sent the implants and the capsules off for not just pathology, not just to kind of look at what's going on in terms of potential cancers or other stuff, but we also send it off for culture. So we send it to the microbiology lab, and they culture that material, and we see what grows. And we're actually finding a striking number of positive growths. We're seeing bacteria and other things, fungus types of things grow out of these implants that would otherwise not be considered to be infected. So it's an interesting finding. It's actually consistent a little bit with some of the stuff we saw with in the previous studies that they did on joints that were taken out that weren't infected at all. So it's, having a chronic colonization of something in your body could potentially lead to you constantly trying to keep it at bay. And so that would be potentially an explanation that we're trying to understand better. And so we're actually working on it actively right now. So
it's almost a quarter of our patients have some kind of bacterial or fungal contamination.
Yeah,
it's surprising though.
It is very surprising. So, in a nutshell, I think that's sort of my 2-minute spiel on kind of what I think implants can cause and how they cause the problems that may have brought you here today. But obviously, those are the things that brought you here, and the discussion, really is about taking them out at this point. And so if we talk about removing implants, it's a surgical procedure that we've sort of done a lot of and become very comfortable with, and I think Dr. Tiwari can talk quite a bit about it.
Yeah, so what is a surgery? And we've all heard of a bilateral total en bloc capsulectomy. What does that mean? So what it means is, I just like to go through the steps of the operation so people understand, how we approach it. So for most patients who've had a previous inframammary fold incision, we'll remake that inframammary fold incision. Now, some patients have had implants placed from a areolar incision around the areola. More uncommonly, they've had an incision at the axilla. The problem with the areolar incision and the axillary incision is you can't really see the entire capsule. And I think that's when you leave capsular tissue behind. So really, you can do the operation through an areolar incision, but the most favorable, most kind of predictable way to do a total capsulectomy is through an inframammary fold incision. So the first step is making that incision, kind of identifying the capsule. For people that have the implants below the muscle, it's then elevating the breast tissue, elevating the muscle off the capsule. If the implants are above the muscle, then of course it's elevating the breast tissue off the capsule. And then removing the capsule off the posterior chest wall as a total en bloc specimen, not leaving any capsular tissue behind. People are always concerned about, can you take the capsule off of the posterior chest wall? And I think we don't really find that difficult. You know, as microsurgeons, both Dr. Kocak and I are microsurgeons, what we do a lot of the time is complex microsurgical reconstruction. So what does that even mean? Well, we're oftentimes taking tissue from somewhere else when we're doing a breast cancer reconstruction and hooking up two very small blood vessels, an artery and a vein, right in this kind of rib area. So we're very comfortable with the rib anatomy, with where the lungs are. So leaving capsule behind is not something we worry about too much. But once we've done the capsulectomy, the next part of the operation is placing drains and sometimes repairing the muscle, advancing the muscle to its normal position to put it back to where it's supposed to be. We always use drains here, and drains are important to avoid a fluid collection, to avoid an infection. On average, the drains are in place for about 5 days. We're always happy for people to come back here for us to take out the drains. Caitlin, one of our physician assistants who you'll meet, Maggie, Michelle, Dr. Kocak, me, we're always here to take out the drains. For some patients come from far away, we can always arrange for drains to be removed at home, but our preference is to take out the drains here. The third part of the operation, which we do in about half the patients, is either a lift or fat grafting, usually one or the other. So who would need a lift? Well, the goals of a lift, there are really three of them. The first is to move the nipple more northward, oftentimes also to reduce the size of the areola. Sometimes with implants, the areola gets stretched out and it's not that favorable for patients. And then the third goal is to kind of reduce the skin to accommodate the new skin envelope to your breast volume so it looks like small implants. And that's a lift. In some patients, we'll do fat grafting. Well, what is fat grafting? For people that have that are very small, have very little breast tissue, we'll maybe liposuction the thighs, maybe the inner outer thighs, and use that fat to build up some of the volume, usually in kind of the upper pole. And fat grafting, I think, is useful in that it improves patient's volume, but it does have some limitations. About half the fat goes away over time. You can plan for that a little bit. Sometimes the fat doesn't just go away, and it can get a little bit hard. That's known as fat necrosis. And for people that are then getting imaging for mammograms or other things, it can be a unintended consequence where it leads to more imaging and biopsy. So I think it's important for patients to know that in the context of fat grafting.
And no, you can't have volunteers come in because that's always, there's always a family member who's just waiting to give it up, but it doesn't work. I wish it did. Trust me, I would be the first to go.
We always do these operations, usually in an outpatient, not always, usually an outpatient surgical center, and we've got a 0% infection rate there. So patients get an IV antibiotic about 30 minutes prior to the operation. We don't typically send patients home with antibiotics because there's really no data that post-operative antibiotics reduce your chance for an infection, but there's clear data that preoperative antibiotics do. We really try to avoid narcotics as much as possible. We use a lot of nerve and muscle blocks. We rely a lot on anti-inflammatory medication. It's also right up the road from Mount Carmel St. Anne's Hospital, which is a full-service tertiary care hospital where we both have full privileges. So not that we've ever had to transfer somebody there, but from a precautionary standpoint, I think that's important, should we ever need to. The capsules, like Dr. Kocak was talking about, we'll send typically for 6 items for aerobic bacteria, atypical bacteria, anaerobic bacteria, fungus, rule out a breast cancer, and rule out a lymphoma, ALCL lymphoma with a CD30 immunostain.
You guys have probably heard a lot about sort of the implants and the lymphoma connection. I didn't even talk about that earlier, but it's something we always talk about as well. Certain implants have been associated with the possibility of what they call DIALCL, which is a pretty aggressive lymphoma, completely separate from breast cancer. And it's been connected directly to the actual texturing process or surface of some implants, not all, but certain implants. So those have been recalled, so they're no longer sold. They're not available on the market in America. But the FDA hasn't necessarily laid down a recommendation to have them removed per se. But if those implants are in there, it's another thing that we always kind of look out for. And that's why we send the capsules to make sure. And there's a specific stain they do, like Dr. Tiwari mentioned, that can actually look for the presence of that. So we always send that with the specimen.
Yeah, we both think this is a health problem, so we try to do it through health insurance. We can get through insurance better than 60% of the time. And there's sort of a process that goes into that. But I think it's important to understand that it's possible, but not always predictable how insurance companies are gonna address this. I do think that most people tend to have improvements when it comes to the mechanical symptoms. You know, a lot of people will say, I didn't realize how much shortness of breath I was having. I didn't realize how much discomfort I was having in the chest and the neck area.
Upper sort of arm limitations and strength, and those things all change pretty quickly and permanently. We see that, I'd say, consistently. If I could ever guarantee anything, I'd guarantee that.
Yeah.
Some of the other stuff, though, is harder to know. We see some improvements, and sometimes they're permanent, sometimes they're not. But we see enough that work out well that it's still worth doing what we do, so that's why we press on.
Yeah. I think the recovery is a week before you're getting back to your normal strength and energy, but it's really about a month before you're getting back to 150%. A lot of times we'll have people in like sort of T-Rex arm type position. For the first months, you're not stretching and pulling on the incision repair, particularly the muscle repair.
'Cause every time you move that arm away, your pec muscle is actually attached to your arm, so every time you pull your arm up, it'll create what's called shear, and that shear movement will create fluid production. And the goal is to, remember, there's a space after we take the implant down. The drain is trying to eliminate the space, so we want this to stick by the breast, to stick back down to the chest. So every time we have shear, it'll break that, sort of restart it. So keeping the elbows tight for a couple weeks is always a good plan while the drains are, doing their best work to keep everything sticking down.
Yeah, about a month, we'll have people start exercising again, like half strength, half magnitudes of like the treadmill for 40 minutes, maybe 20 minutes half as fast. And then kind of gear up your activity level so that when you're 2 months post-op, you're kind of back to your full exercise level. I think that for most patients, I think of problems, you always kind of, hope for the best, plan for the worst. So what are the problems? So I think of the problems as short-term, medium-term, and long-term. So what are the short-term problems? Probably the main thing that we worry about is bleeding, also known as a hematoma. So oftentimes we'll see you the next day, maybe the day after, to make sure the drains are working okay, to make sure there's no bleeding. And that's kind of our short-term concern.
If you're coming from far away and you're coming in, it's an outpatient procedure. We'd usually recommend, I like sort of the hour and a half cutoff. If you're farther than an hour and a half away, we usually recommend staying in town. And I will usually, tell other patients the next morning, checkout's usually around noon. So if by noon things look okay, they're probably okay. But if there's any question, we can see you before you leave. But if everything looks okay and you feel all right and nothing's changed, hop in your car and go home. That's usually the best course of action. If you're inside the 1.5 hour loop, usually we can manage stuff. Even if you were to start to have something bleed, we'd be able to get to you and meet up in time to be able to manage it. So
that's a short-term complication, is bleeding or hematoma. What's the medium-term complication? Probably a seroma. So again, the goal of the drains is to remove fluid, so fluid doesn't collect in the early days after surgery before your body can make scar. It makes fluid. If that fluid isn't controlled, that's how you get an infection. So after maybe the 2-week mark, the 2 to 4 week mark, we worry about a seroma. Again, that's where that activity limitation comes in, keeping your arms in that position, because a lot of that movement creates fluid, which can then become a seroma.
the best way to prevent a seroma is to keep that drain in long enough. So we'll do surgery, and usually you'll have a follow-up appointment about a week later, the next week in our office. If the drains are still putting a lot of fluid out at that point, we'll give you a number. It's usually around 30 cc's. We'll actually encourage you to just reschedule your appointment and come in a few days later so that the drains are actually really ready to come out, because the drain is really the easiest way to prevent a seroma from being a long-term problem. If it happens after the drain is out, then we have to use maybe ultrasound or radiology to help us put drains back in or get the fluid out. So it can be a little bit of a nuisance. So it's better that the drains do their work on the front end and actually keep that seroma from occurring. So it's...
What are the longer term complications? Well, I don't know if these are really complications. I think we both understand how anxiety provoking this is, even to come here today, like how anxiety provoking that is, and how difficult it is when you're not feeling well to make decisions like this, and put yourself in a position where you're becoming vulnerable and you're talking about surgery. All that's very anxiety provoking. And I think another anxiety is what am I going to look like afterwards? And I think there is improvement. For most patients, there's people will call it fluffing. For us, that means kind of wound contraction,
skin
wound
contraction,
healing, skin contraction. But at 3 to 4 months, that's when we kind of critically take a look. What are things that we can make better? Maybe it's maybe a lift if we hadn't done one then, although pretty unusual to have to do a lift down the road, maybe fat grafting, and that's maybe a little bit more typical to do some fat grafting later on. But I think those longer term issues tend to be more aesthetic issues, and I think one thing I love to tell people is, like, I know how anxiety provoking this is. We can always get you to a very proportional, balanced, symmetric outcome, so don't be anxious about that piece.
Yeah, and it does certainly take, 3 to 4 months to let that tissue really kind of do what it's going to do. Early on, it's, now that we've done this for long enough and seen so many cases, there are things that may not look, great, or something that's a little concerning, but a lot of them actually end up settling out okay. So patience is key. It does take a little bit of time for things to settle. There are things we'll do along the way to try to manage things that might be happening. We can massage, we can do certain things to get the tissue to maybe move a little bit. But I think for sure it's about waiting long enough to make sure that things have settled so we know what we're going to have in the long term.
Yeah. Why don't we pause here and see if there's kind of general questions that people have before we kind of break up for individual consultations.
If we haven't covered it. Let's
you
see.
answered a lot of my
Geez,
questions.
we're good. Yeah.
Do you recommend a certain diet, like an anti-inflammatory diet, or I've been reading about all these different diets to
Yeah, I
try
think that's
to.
a great question. So we've done a handful of these sort of group consultations now. We found it a great way to actually learn ourselves, because then everyone kind of gets to field questions like that. That was a common question. So we actually, early on, we teamed up with, her name is Lauren, and what's her little thing called? Lauren, what's her little?
Whole Living Lauren.
Whole Living Lauren. Whole Living Lauren is awesome. So Whole Living Lauren has sort of educated us on this. She's very committed to, I would say, in a nutshell, her whole commitment is to really natural types of diets and nutrition in order to manage, not just your overall nutrition, but things like inflammation. And so I would highly recommend hopping into her site. And I think we actually have some content from her that was specifically made to answer this question. So we do have some basic thoughts, but these are, just recommendations. They're certainly not requirements, but if you're committed to, doing something like that, and those things we always support a lot. Being nutritionally replete in a healthy way is no question going to be beneficial for the healing process. So we're very, very strong proponents of that.
But I don't think we have like a regimen, because I think, detoxification, nutrition, these are so individual, based on people's genetics, your body mass index, your lifestyle. It's hard to just kind of use a broad brushstroke. So someone like Lauren kind of really individualizes, and we have no relationship with her other than she's someone who's really smart and does a good job.
Yeah, and she's committed to really natural solutions. Our whole practice is kind of our practice evolves around natural solutions for everything. We do a lot of breast reconstruction. A lot of the breast reconstruction we do is largely committed to natural, using tissue, using fat, using whatever we can that's as much as possible avoiding the implant materials. In our practice, from a cosmetic standpoint, all the cosmetic stuff we do to breast are lifts and reductions and fat grafting.
We don't put any implants.
We don't put any cosmetic implants in at all anymore. They'll call our office. We send them over to our colleagues in town who are doing it. We're really committed to sort of a natural process for people, and so that's why we really align with a person like Lauren. I'd really recommend popping into her little website. I think we have her stuff right here somewhere. We'll put it out, and you guys can check it out.
Thank you.
Anything else? Yeah.
How long is the surgery typically, and how quickly do you leave, or do you stick around?
Yeah, absolutely.
How long
So,
do you discharge?
So just the removal. So if we're not doing a breast lift at the same time, taking 2 cosmetic breast implants out, it's an outpatient procedure, and so the actual surgery itself takes just about 2 hours. Actually, a little bit less than 2 hours. And then if we're doing a lift at the same time, it could add about an hour to the case, maybe a half hour. So anywhere from 2.5 to 3 hours if it's removal and a lift. Fat grafting is sort of the same. So if there's fat grafting and removal, it's about the same, 2.5 to 3 hours. After surgery, you go to the recovery area in the outpatient center. And once you're recovered, usually takes an hour and a half to recover. That's the whole thing. Then you'd be discharged from the center. But like I said, if you're from farther away, we'd recommend staying in town and being nearby, because we really want to make sure in that first 12 to 24 hours that everything goes okay and there's no bleeding situation. So, but that, for most cases, that's the course.
And then you follow up in a week?
Yeah, typically the first follow-up appointment is about a week when the drains would come out at that time. Like I said, if the drains are still a little bit high, reschedule for a couple days later. We want to take them out when they're ready to come out, because then they're still doing work. We don't want to let them, they're our friends. Even though they're not comfortable, they're friends. And then typically, once they're out, we'll see you back usually around the 2-month mark, so we can kind of see how the tissue's settling. And I mean, do you usually see people in between there?
No, that's not.
Yeah, somewhere around that 8 to 12 week mark. It's not very rigid, but we just want to get together and make sure the tissue's settling okay. We want to make sure that things are actually coming around. Now, if anything pops up, we would see you sooner for sure.
Now, we always take pictures of the capsules, of the implants. We can get the implants back to people usually, if they'd like. If there's something interesting, we'll take some video. We'll send people, patients home with a support bra, so that really is like your post-surgical garment, just like if you sprain your ankle or break your arm, you're in a wrap or a cast, the post-surgical bra is your post-surgical garment, so we'll send you home with that.
Yeah.
How long before you can drive?
So driving depends on really just 2 things. So it's never like a set number. I would say, if I had to guess, I'd say around a week. But you can drive with drains in. It's certainly okay. So the drains don't have to be out, but you have to be off of any narcotic pain medication. We really don't see people take long-term narcotics after this operation. You might take a couple pills here and there, mostly at night. Most of the pain is managed with sort of non-narcotic pain medications like ibuprofen and Tylenol type of stuff. So if your pain is controlled without narcotics and you feel like you can react, as long as you can react, so you just have to be able to have adequate mobility of your arms to be able to react when you're driving. I mean, I think a week is a reasonable number.
Yeah, I think the safest time period, just wait till the drains are out.
But I've had plenty of people drive themselves in with their drains removal. But it's just, again, you have to be comfortable reacting to, traffic, so.
Are there any sutures that you have to remove after you take the drain out?
So the only suture that is on the outside typically is the one for the drain. So that one we just kind of cut. It's got a sort of a loop on the outside of the skin. It's easy to remove, and that then frees up the drain. And the drain we use it's called a hubless drain, which means it's actually 1 diameter all the way. So if you cut that stitch, it usually will fall out on its own. And I think a lot of people have a lot of anxiety about drains being painful. And it's typically because if they've had a drain previously, the drains a lot of people use are actually bigger on the inside than on the outside. And so when it passes through that skin, it actually stretches and it hurts. The drain, and they also have little tiny holes that the tissue starts to kind of grow into. Ours doesn't. It's actually got these sort of little strips, and so tissue can't really grow into it. And so it's 1 diameter and it's silicone, so it actually comes out and slides right out. It's actually very painless when the drain comes out. If we do a breast lift, sometimes we'll put a couple stitches on the outside where the incisions come together like a T, because those T areas have a little bit of extra tension, and that external stitch can help keep that area together. So we would take that out, usually at the time the drain comes out.
Yeah, the breast lift incision is always this inverted T incision. So there's a lot of different types of breast lifts. I think in the context of a total en bloc capsulectomy implant removal lift, it has to be what's known as a wise pattern incision, inverted T incision. Anchor incision. With an incision around the areola, down to the fold, and along the fold. And that's how you move the areola north and kind of reduce some of the skin like we were talking about.
Those are good questions. Yeah.
Would we be able to see how many cc's is coming out of the drain?
Oh yeah, so
I mean,
the drain
just
goes
as a
into
patient.
and so we can actually shoot, it goes into a little grenade. We're gonna have little videos on all this stuff soon too, which is yay. They worked hard last week to do it. Yeah, but this is a little grenade and it's a little bulb, and it's got little lines on it. So when you look at it before you empty it, you actually just see the number and we usually have people just write it down on a little piece of paper that you'll get in your pre-op packet, and you can just keep track so that you know if you have to empty it more than once a day, then you have a running record of because per day we really like that number to be less than 30.
So we're emptying it as we go?
You are emptying it, yeah. So each day you'll have to empty it once, maybe twice, but usually once a day you'll be able to empty it. The drain works best when that little grenade is collapsed because it creates suction on the drain, and so that suction then gets transferred to this space and it sucks everything down, which is what we want to happen early on. We want everything to suck back together. Drains are everyone's least favorite part of every surgery.
That'll be the hardest part of the whole process.
I'm yet to meet someone who loves their drains.
Nobody loves drains.
Yeah.
Sorry. What's the longest somebody's had drains in for?
I mean, probably 10 days, yeah,
Oh, really?
for this operation.
Because I've had drains before and they were in forever.
Yeah, no, I'd say, in my, will you? I mean, I've not seen them go past 2 weeks for this.
I've had a couple patients who are have a very high body mass index that it can be a little bit longer.
Some people who get really, really active early on, that will drive the fluid production quite a bit. So you feel good. I'm like, well, I guess I'll vacuum and go do the elliptical and whatever. That's bad news because that arm movement is what creates all the fluid. So, you know, if we're driving the fluid production up, it could stay longer. I mean, it's really key to give that upper body the rest. That shoulder needs to stay quiet. I'd be shocked if it stayed past 2 weeks for this operation.
Are the implants returned to the patient, or do you?
Yeah, so they can be. We certainly have a process to get them back to people. I'm a fan of actually sending them with the capsule to the pathology department, because what the pathology department will do, because there's all these recalls and stuff going around, so they will actually do what's called a gross inspection. So they'll actually say, is it ruptured or intact visually? Because again, it's a visual inspection. They'll also kind of say what they see. This is a smooth or textured device. And then there's usually a little logo on it. If it's not too old, that logo still is embossed with the information. And they will then say, this is a, you know, Allergan textured device, serial number, volume, blah, blah, blah. So then we have sort of this like record, right? That the device was either intact or ruptured, and it's an official record. It's a pathologist has stated it in a medical document. So for that reason, I'm a fan of sending that to the pathology department.
Okay. Yeah.
Because,
I've read a lot about getting returned. Like, what am I going to do with them?
Yeah, some people, yeah, and a lot. So I think there's been some. I think a lot of people like to kind of, you know, like see that they got them out or kind of like document. And there's a lot of, I think, you know, excitement about getting them out, and people, I think they sometimes just want to take a picture with them, right, or something. That's fine. So we have a whole closet of old implants back there. If you want samples, you can go back there and take all the pictures you want, if that's what it is. But at the end of the day, we have a process to get back to people if they want them.
I think it's more from the lawsuit, like if there is a class action suit.
Yeah. So in that context. Once that device leaves our hands, it's probably not going to have a lot of credibility, right? Anything could happen to that device once it's out of. That's why it's probably best to have it in sort of a pure chain of command going straight to the pathologist where there's documentation about what it was, because it can't be manipulated in that setting.
We have a celebrity guest appearance with Ms. Graham, who's a patient of ours, actually been through some of the surgeries we've been talking about, so I'm sure.
I was just hanging out at home and I
Yeah.
saw you were on Facebook Live and I thought, well, I'll come in and see if anybody has questions from somebody. If anybody's considering flat closure, I went flat, and so if anybody really wants to see the
cool.
scars or see what it looks like.
Yeah, we do obviously we do a lot of total en bloc capsulectomy implant removals, not only for people who've had cosmetic implants, but also in the breast reconstruction arena after mastectomy. That's a completely different conversation, but there are a lot of similarities as far as the drains, the recovery, and all those types of things.
Yeah.
So appreciate that.
Any other questions?
I have one more question.
Yeah.
So I've been dealing with SIBO and lots of antibiotics this past year, and I'm finally at a place, kind of has to do with the inflammatory diet. I'm finally at a place where I'm feeling okay, and I'm so nervous that surgery is going to kind of like flare all this up again. So have you had any patients that have been dealing with SIBO or SIFO or something along those lines that you're aware of?
You have to tell me what SIBO or
Oh,
SIFO
small
is?
intestinal bacteria overgrowth.
Okay.
So
Yeah, I mean, personally, I could talk about this topic for a year and a half. So I'll just give you and a lot of these are my opinions.
Please don't do it for a year and a half.
So these are my opinions.
It's warm.
I think that our gut bacteria have a tremendous impact on our overall health. You know, your gut bacteria, if you go vegan, your gut bacteria will change in about 24 hours. If you go carnivore diet, your gut bacteria will change in about 24 hours. I think it has a tremendous...
He's done all these things.
I know. So it has a tremendous impact on kind of our overall wellness. And I think one thing we hear a lot is patients will try to, quote unquote, eat clean. You're going gluten-free, you're cutting out certain things from your diet. It does improve your symptoms. And I think that makes sense if the kind of underlying mechanism for breast implant illness is an inflammatory response, either to a low-grade bacterial contamination, as we see in the capsules, or to maybe the silicone surface in general. But if it's an inflammatory response, and you're generally speaking decreasing the pro-inflammatory stimuli in your body, I think you are going to see improvements. I don't know of anyone who's had a worsening after surgery. I don't think surgery is a stressor, but I wouldn't say it's an inflammatory stressor.
It's a transient inflammatory, so there's no I mean, surgery causes a systemic response. You'll have but it's transient because the insult ends. And so when the insult ends, I mean, it's not, you're going to go back to your baseline state. Right. So it'd be unlikely that you would disrupt an equilibrium. It would have, I mean, it'll come off, but it'll go back to where it is because it's a transient stress.
Yeah, I think if you were to like plot it out, you probably have like a peak in inflammation in the month post-surgery because you are in an inflammatory response or healing a wound. But I think you then go back to baseline as your swelling goes down, as your, as all those markers would return to baseline. And then, again, I don't know of anyone who's had a worse outcome.
Okay. Thank you.
Anything else?
I have a question.
Yeah.
Is there any advantage to, prior to surgery, focusing on strengthening your pec muscles, or is it, do you ask patients to kind of avoid that, or is it just?
I don't think you have to change anything prior to surgery, especially as it relates to the sort of the pectoralis. I mean, if the implant's under the muscle, your pec muscle during the process of placing the implant, the pec muscle is divided along the lower part where it attaches to the ribs, but the rest of the pec is still intact. So it comes up along the sternum and actually all along your clavicle up here. So this whole part of the pec is still intact. It's just this lower part that gets divided during an augmentation. A lot of times the muscle will kind of thin away, but working it out or trying to train it in this setting is not going to make it much stronger because it's already as strong as it's going to get where it's attached.
Right.
The part that's not attached isn't going to train, so that's the part we're going to kind of pull back down to the chest wall. So I don't think it would make a huge difference either way.
Okay.
I'd almost recommend lazy than don't
I like
by all means. Promote laziness. Yeah.
How would you handle like an intracapsular rupture versus an extracapsular?
That's a great question. Oh man, boom. You want this one?
Yeah. So
No, I want this one. No, you don't.
So this is how we approach this, which may be a little bit different than some of the things that you read. So, and we're going to dive into the weeds of the surgery a little bit. So oftentimes, you don't know necessarily if there's a rupture. As you're doing the capsulectomy, number one, extracapsular rupture is very unusual.
Yeah, especially with the devices. Unless you've got a device that's 20 plus years or older, the silicone that is in these devices these days is highly cohesive, even in the basic devices, and so it's very rare to get an extracapsular rupture with the current devices. I mean, very rare. It's not that common at all. So I would take that as the first thing.
Yeah. So an intracapsular rupture, it's not always clear that it's ruptured. But as you're doing the capsulectomy, some of the capsules can be quite thin. There's also sometimes almost like a filminess there. That's like a hallmark of a rupture. And so what I will do if I see that is, so the capsule is like it's like a basketball, it's a sphere more or less. And you don't want to, as you're doing the capsulectomy, you don't want to be in a position where you, by mistake, make a incision in the capsule on the back end of the basketball. Because if that happens, you can't really see it. You can't really control it. And that's where you'll get silicone contamination of the breast tissue. So if I see that filminess, I will actually make an incision in the anterior part of the capsule, the part that I can see very easily. So in a very controlled fashion, we have a kind of a suction system to remove silicone. This is really for silicone implants. And in a very controlled fashion, we'll remove all the silicone. So there's no contamination of the tissue. We'll kind of towel it off. But I think that you have to do that because if you are on the backside of that basketball, you have no control as to what's going to happen, and it'll become a mess. So that's how we deal with an intracapsular rupture. I've never actually seen an extracapsular rupture.
Well, so most of the time, the extracapsular ruptures, they've been there for so long that the tissue is actually calcified in those areas, and the capsule is very, very, very thick around it. So we'll take the en bloc implant and surrounding capsule will come out, but it'll be a very obvious area where it sort of has come out, and you see that it comes out with it though. The key is the whole key is this is a balloon that's full of something, right? Silicone, water. Don't pop the balloon, just stand outside. So as long as you can do that, then this is okay. And like Dr. Tiwari said, if there's a really thin area, and that's the area where there's a problem, if that area is going to be a problem, that's when you evacuate. But I mean, we've done hundreds and hundreds of these, and the need to actually evacuate, like, you know, loose silicone outside of, like, in a non-en bloc fashion, I mean, I can only think of one instance, so.
I do have a rupture on the outside. They found it with the ultrasound, so is that gonna be a problem?
Typically, the ultrasound will show that, and at surgery, it is, like I told you, the capsule has encapsulated it. So I don't think that, we've seen plenty of ultrasounds that say that, and at surgery, that's not how it comes out. So I would actually not be too concerned, yeah.
I guess the point is there's a capsule around the free silicone because it's sort of,
It's another implant, so the body kind of just capsulates it off, and it just comes out with the whole thing. It's good to be aware.
Yeah.
So going in, we're going to be very cautious, and we're going to know that. So yeah, there's the chance that we'd have to deal with it, but we have a process for dealing with it. At the end of the day, all the silicone is going to come out of your body, as well as all the capsule. Now, some of the really old implants, which were liquid silicone, they could get into the tissues and cause what were called silicone granulomas, and those were kind of remote and farther into the breast, like little spots. Those are different. Those are hard. You have to go chase those individually, but I've not really seen that in a long time. It's then, you know, again, that's a very specific situation.
I think the key is that all the capsule comes out, and the goal is to avoid any contamination of the tissue.
With that all said, do you recommend an ultrasound or a mammogram or an MRI or anything before surgery?
That's a good question. We don't typically, and we don't because we try to do this all through insurance, and sometimes, you know, the insurance process is difficult, and it's not exactly clear what they're looking for sometimes. So I think in general, like just sort of sticking to functional limitations, sticking to those types of range of motion issues is the best way to address.
But if there's like an obvious mass or something, or we feel something nodular, if there's any real concern, an ultrasound or an MRI is something we would do, but it's extremely rare that we would feel something obvious.
But we don't require it.
It's not required by any means.
Would the insurance more likely to pay if there is evidence of a rupture? I don't know.
I think that's true. And the flip side, I think, is also true that if there is no rupture, then it's unlikely. If there's no documented rupture, then it's
This
unlikely.
is more often the case that there isn't. The only way to really pick up a rupture definitively is on MRI.
Yeah.
And that study is traumatic, first of all, and it's also difficult to get.
I've had the MRI and the mammograms and the ultrasound, and I do have an intracapsular rupture. So that won't hurt insurance chances, because I was thinking that might help
No, if anything, I mean,
think it will help.
you have a mechanical failure of your device that's documented, so that will go into the record.
That's an ICD-10 code. Is
Yeah, that's a mechanical failure.
mechanical failure of the implant.
It's a diagnosis code that's specific, so, I mean, it's nice that it's intracapsular, so that'll make the surgery somewhat more, tolerable.
But that's a good example of somebody that we would do a controlled removal of the silicone because we know that there's a rupture.